everyone. I'm Dr. Shamni, your mentor from StudyMedic. Welcome to the YouTube series MRCPI. And today I'll be covering the Oncology module, two topics that will be cervical screening as well as CA cervix. We'll be discussing the most exam tested points and also some SPAs. Let me start. So let's first discuss about cervical screening. So basically, you all know about the age group who has to be screened, right? It is 25 to 65 years. So the primary HPV testing is the test what was done during the screening, and cytology is used only as a triage if HPV is found to be positive. So what if the patient is high-risk HPV negative? So if the patient is negative, HPV negative, in the age group of 25 to 29 years, you have to repeat the test after 3 years. So this can be a SBA. Again, 30 to 60 years, we have to repeat in 5 years. So it's 3 years and 5 years. Age group 25 to 29, it's 3, and 30 to 60, it is 5 years. So more than or equal to 61 years, screening is actually completed. What about post-hysterectomy done for a benign indication? No further screening is advised unless advised by colposcopy or oncologist. If the patient is HIV positive, then we'll have to do annual screening. So this is actually a recall, and this you have to remember. It is 1 year for HIV positive. Post-colposcopy, there is increased surveillance, and we have to follow colposcopy with discharge advice. So what if the patient is detected to be HPV positive, high-risk HR-HPV is positive, but the cytology is normal? In that case, what we have to do? So first HPV with normal cytology, we have to repeat HPV test in 12 months. If the second consecutive HPV is also positive, but there is normal cytology, then we have to refer for colposcopy. If the patient is HPV positive and HIV positive, then we will have to refer for immediate colposcopy. For HIV positive patients, if HPV is positive, need not wait, but immediate colposcopy should be done. So, okay, so next scenario is where cytology is abnormal. HPV is positive, but cytology is abnormal. So in that case, it depends on the cytology report. So if the cytology is showing any low-grade squamous intraepithelial lesion, high-grade squamous intraepithelial lesion, or abnormal ascus or AGC, whatever it is, we are going to refer for immediate colposcopy. Now, HPV is positive and unsatisfactory cytology. In this scenario, what you're supposed to do? We'll have to repeat again in 3 months. So again, HPV is positive and cytology, any abnormalities is seen, we have to refer for immediate colposcopy. If HPV is positive and unsatisfactory cytology, then we'll repeat again in 3 months. Now, another scenario, you are doing HPV and it is found to be indeterminate or equivocal, then what we have to do? So the first and second indeterminate result, we have to repeat in more than or equal to 3 months. But if you get 3 consecutive indeterminate results, then we should not wait. We have to refer for colposcopy. So first and second result, you will just keep on repeating 3 months at 3 months interval, and third consecutive result, you are referring for colposcopy. So any 3 abnormal screening tests in last 10 years without colposcopy. Imagine a scenario like this. Patient is on irregular follow-up. Any 3 screening tests in last 10 years without colposcopy, you have to do a colposcopy for that patient. Now, another scenario where test is not processed, that is, sample is not adequate, it is not processed, then we have to repeat in 3 months. Now, some special clinical situations. So, if at all in the cytology you see endometrial cells in women more than 40 years, patient should be out of the cycle, remember. In that case, we have to refer for a gynecology assessment. So this also can be an SPA. Another scenario where any postcoital bleed, intermenstrual bleed, or postmenopausal bleed is noted, then also we have to refer for a gynecology assessment. In case during examination you are finding a clinically suspicious cervix, do not take smear, just refer for a colposcopy. Now, let's discuss some questions based on this. A 27-year-old woman has a HPV test which is negative. She has no abnormal history. What is the screening interval? So this we have already discussed. Answer is 3 years. Next question. A 34-year-old woman has HPV. HPV is not detected. What is the next recall interval? So this is 5 years, because the age group you have to remember from 30 to 60 years, it is 5 years. Next question. HPV is positive, but cytology shows ascus. Then what we have to do? Yes, the answer should be referral for a colposcopy. All this scenario we have already discussed. Now, HPV is positive, cytology, no abnormalities detected. So what is the next step? This is the first occurrence, okay? HPV is positive, cytology, no abnormalities detected. First occurrence, what is the next step? We have to repeat again in 12 months. Next question, HPV is negative, but cytology shows endometrial cells out of the cycle in a 45-year-old woman. What should we do? We have already discussed this. It is going to be a gynecology assessment. Refer for gynecological assessment. Now we'll discuss the colposcopy algorithm. So you know the situations where we refer for colposcopy, right? Now what happens during colposcopy? So let's discuss this block first. So you are referring the patient for colposcopy and the patient is HR-HPV positive and the cytology is either normal or low-grade abnormal cytology. If you are referring this group of patients for colposcopy, and the colposcopy is normal, colposcopy is adequate and colposcopy is normal, and or there is no CIN reported on biopsy, in that situation you have to call her after 3 years. Okay, so the next recall will be after 3 years regardless of the age. Okay, in any age group this is going to be after 3 years. So this block is clear. So now let us discuss the first block. For this group of patients where HR-HPV is positive, but the cytology say the normal or low grade, then what we are going to do? If you get a unsatisfactory colposcopy, where the scoma columnar junction is not properly visible, or the transformation zone is type 3, then it is called as an unsatisfactory colposcopy. Then what you have to do is, we have to repeat the HR-HPV test and colposcopy, HR-HPV test in colposcopy after 12 months. Okay. Now, after 12 months, when you repeat, HR-HPV comes as positive and still it is unsatisfactory colposcopy, then what we have to do? We have to consider LEDs. So 2 times we are doing. First colposcopy unsatisfactory, we are repeating after 12 months HPV as well as colposcopy. And if it is positive, then what we have to do? Again, if it comes as positive and if colposcopy is unsatisfactory, then we have to consider LEDs. If at all LEDs is done, we have to do the test of cure. Now, if LEDs is not done due to many reasons, then we'll have to monitor with colposcopy itself after 12 months. So this block is also done. So this is done, this is done. Now we will go for a situation where the patient is HR-HPV positive and the cytology is either low-grade abnormalities there, or if it's normal, then what we have to do? In these patients, colposcopy is done and it shows CIN1. Okay, colposcopy done and shows CIN1. What we have to do? We have to test after 12 months. After 12 months, we have to do. If after 12 months, CIN is actually a low-grade lesion, right? So if after 12 months, if HR-HPV is negative, then okay, we will call her after 3 years, regardless of the age. But if in 12 months, if HR-HPV comes as positive, what are you going to do? Definitely you are going to do cytology. And if cytology is normal, no abnormality was detected in the cytology, again you will call her after 12 months. Okay. If HR-HPV comes as negative, When you call her after 12 months, you can directly go for a 3-year recall, regardless of the age. But if it comes as positive and cytology is no abnormalities detected, so twice it is occurring like that, so you have to refer for a colposcopy. Okay. So you are doing colposcopy, it comes as CIN1, call her after 12 months. If negative, it's fine, 3 years recall. If positive, again go for the cytology. Cytology, if nothing is there, no abnormalities detected, you are repeating it after 12 months. And if in 12 months, again, if it comes as negative, go for a 3-year call. If it comes as positive, even if cytology is normal, then we have to go for a colposcopy. Now, here, after the first 12 months testing, if HRHPV comes as positive, then you have to go for cytology. If it's abnormal, more than or equal to ASCA, any abnormality, you have to refer the patient for colposcopy. So that is about the third block. Now the fourth block is the first colposcopy itself shows higher grade lesions like CIN2+. Then we have to call for a MDT if you are planning conservative management. Call for an MDT if you either you treat the patient or call for an MDT if you are planning conservative management. So all the 4 blocks are clear. Now we will discuss the second algorithm. Here the patient is HRHPV positive and there is high grade abnormality in the cytology or any abnormal glandular cells. In these patients, what are you going to do? Definitely you are going to refer the patient for a colposcopy. In colposcopy, if nothing is seen, if no abnormality is visualized, there are 2 blocks. If the colposcopy is unsatisfactory, like we discussed before, definitely we have to go for a LETS or MDT. If you're going for a LETS, definitely go for a test of cure. Okay. Or as based on the MDT recommendation, you will follow up the patient. Again, colposcopy is done, and if it's satisfactory colposcopy, then if biopsy is showing low grade lesion like CIN1 or less, even if it is so, because the initial cytology was abnormal, high grade abnormal cytology or glandular abnormality was there, because of this factor, even if it's less than CIN1, we are not going to wait. We will directly go for LETS. So that is the difference between the previous algorithm and this algorithm. Okay. So if it's satisfactory colposcopy, even if it's come as a low grade lesion like CIN1 or less than that, we will definitely go for LETS or MDT because the patient was HRHPV positive and high grade abnormal cytology was detected initially. Okay. If LETS is done, definitely a test of cure is done. Otherwise, MDT will decide what to do. Now coming to the next block where the colposcopy done for this group of patients is abnormal, and if the abnormality is more than or equal to CIN2, that is high grade lesion, there is no doubt the treatment that you have to treat the patient or MDT if at all any conservative management is done. If you are doing LETS, you are supposed to follow up with the test of cure. So that's all regarding this algorithm. Now let's discuss the third algorithm. So third algorithm is you have already done colposcopy and you have managed the patient. So you have treated the patient. So you are calling the patient for a test of cure following the treatment of CIN. So when do you call for test of cure? You will call the patient for test of cure, that is colposcopy, 6 to 9 months after the treatment. So this is also a question. 6 to 9 months after the treatment, you are calling the patient for the test of cure. Now, in this situation, if the test of cure, during the test of cure, you are doing HRHPV, and if it comes as negative, then what to do? If it comes as negative, we have to call the patient after 3 years, regardless of the age. Okay, so treatment is done. After 6 to 9 months, you are calling the patient. And if HRHPV is negative, 3 years recall, regardless of the age. Now, HRHPV in colposcopy 6 to 9 months post-treatment, if it comes as an indeterminate test or not processed, then what to do? So if it comes like that, you call the patient after 3 months. Again, you have to do the screening test in 3 months. And if the screening test in 3 months comes as negative, yes, no problem, you can call her after 3 years, right? But if the screening test in 3 months comes as HR-HPV positive, then we'll have to manage the patient in a different method, which I'll be discussing, okay? So either 6 to 9 months after the treatment, when you are following up the patient, it comes as HR-HPV positive, or the screening test for the previous block for indeterminate test comes as HR-HPV positive, you have to refer the patient for colposcopy. There is no doubt. Now, you have to you have to do a cytology, and also you have to refer for a colposcopy. So you have to see if the cytology was normal and colposcopy was also normal. In that case, you can call her after 12 months. Okay. In 12 months, you do a HR-HPV. Okay. If it comes as positive and if cytology is normal, again go for a 3-year call. So if HR-HPV is positive and you have, if the cytology comes as normal, you can call her after 3 years. But if HR-HPV is negative, you directly call her after 3 months. Okay. So that is the case where cytology is normal and colposcopy also is normal. Now imagine a case where cytology is showing more than or equal to ascus, or the colposcopy is abnormal. In that case, if the cytology, colposcopy and or biopsy, all the problems are low grade, if there is low grade lesion, then you have to repeat HR-HPV after 12 months. Okay. In 12 months, if it is positive and cytology is normal, no problem. You can call her after 3 months. Or if it's negative, directly call her after 3 months. Okay. That's all regarding this block. So next block is where you did a colposcopy, cytology is showing ascus and colposcopy is abnormal. And if the cytology, colposcopy or biopsy is showing high grade lesion, then what we have to do? We have to consider a repeat treatment, or we have to do according to the MDT decision. Okay. We have to go for repeat treatment, or we have to go for the MDT decision. Now, another scenario where colposcopy is performed during test of cure, you are seeing that HR-HPV is positive, colposcopy is unsatisfactory. Then what to do? We can consider repeat treatment, or we can do according to the MDT decision. So I hope that is clear. So this block also, one thing I have to discuss is, in the first block where colposcopy is performed, cytology was normal, colposcopy was normal, then you repeat HR-HPV after 12 months. And if HR-HPV is positive, but if cytology comes as ascus or more, then we go for a repeat colposcopy. Okay. So all the blocks we have discussed. So in this block, one more point what I have to add is, so this is the first group of patients where we discussed HR-HPV was positive and the cytology was normal or low-grade lesion. Here, after when we see an unsatisfactory colposcopy, we repeat HR-HPV in 12 months, and if it comes as negative, we are going to call the patient after 3 years, right? But there are special circumstances when we have to consider treatment, and these circumstances are when age is more than 40, if there is previous CIN, risk of non-attendance, or the women's choice. So that's all regarding all the algorithm. Now we'll discuss some SBAs. So based on this algorithm, 32-year-old woman has HR-HPV positive with normal cytology. Colposcopy is satisfactory and the biopsy shows no CIN. What is the next step? So the answer is, it's normal colposcopy. We'll have to return to a 3-year program, right? So answer is D, 3-year program screening. So HR-HPV is positive and there is low-grade squamous intraepithelial lesion, but the colposcopy is unsatisfactory. No visible abnormality. What is the next step? This also we have discussed. The answer is B. We have to repeat the HPV at 12 months. HR-HPV is positive, but it is high-grade cytology. But the colposcopy is satisfactory and biopsy shows CIN1. Then what is the management? So answer is C. Let's we have to do. Because of the factor that the cytology is high grade, even if colposcopy is satisfactory and biopsy shows CIN1, which is a low grade lesion, because of the fact that the cytology shows higher grade lesion, we have to go for LETS. So it is treat the patient with LETS. Abnormal glandular cytology and HR-HPV is positive. Colposcopy is unsatisfactory. In this case, what to do? The answer is B, which is LETS or MDT. After CIN treatment, HR-HPV is positive at 6 months. During test of cure, you are seeing that HR-HPV is positive. So the next step is answer is C. We have to refer the patient for colposcopy. A 13-year-old girl present to a vaccination clinic. She has no medical illness and is not immunocompromised. She has not started sexual activity. What is the most important HPV vaccination schedule? So we are going to discuss the next topic, the CA cervix and human papillomavirus vaccine. So the schedule of HPV vaccine is very important. So this girl is a 13-year-old girl. So the answer is D. 1 or 2 doses can be given to this girl. So this is according to the new WHO update 2022. So human papilloma virus persistent high risk HRB is a necessary risk factor for CA cervix, and 90% of infections clear within 2 years. But 10% will persist and there is risk for CIN as well as CA cervix. We have to understand that 78% of the cases are due to HR-HPV 16 and 18. The other causes are like due to HPV virus 31, 33, 45, 52 and 58. It accounts for 18%. So this is very important regarding the vaccination. So vaccination is definitely a tool of primary prevention. Available vaccines are bivalent vaccines, which can act against 16 and 18 HPV. Quadrivalent vaccine is available, 6, 11, 16, 18. They're effective against these HPV virus, these strains. And now nonavalent vaccine is available, which can act against 6, 11, 16, 18, as well as 31, 33, 45, 52, and 58. So according to the latest update of WHO, 1 or 2 doses may be given for the age group 9 to 20 years. And for more than 21 years, we have to give 2 doses for sure. And if the patient is HIV positive or immunocompromised, we have to give 3 doses. So it is said that single dose will have a 92% protection against 16 and 18. And impact of this vaccine is that there is 83% reduction in the HPV 16 or 18 in the age group of 13 to 19 years, and also 88% reduction in the invasive cancer. So the preferred screening test with highest sensitivity. What is the preferred screening test? You all know the answer, and it is HPV DNA testing. Now let's discuss the staging. Now this is very important. So basically only some differences are there with regards to the older staging. Initially we had staging in the year 2018 and it is updated in 2025. Very small differences are there, which is also included in the table. So stage 1 is very simple, that is CA cervix, which is confined to the cervix. Okay. Extension to the uterine corpus should be disregarded in this case. As you know, staging can be divided into two, stage 1A and 1B. Stage 1 is again divided into 1A and B. 1A is further divided into 1A1 and A2. So what is 1A? 1A is basically invasive cancer that can be diagnosed only by microscopy. That is microinvasive cancer with maximum depth of less than or equal to 5 mm. Okay, so stage 1A1 is less than or equal to 3 mm invasion, and A2 is more than 3 mm but less than or equal to 5 mm invasion. So that is clear. Now coming to the next stage, that is stage 1B. Stage 1B is again divided into 1B1, B2, B3. So B1 is, so here we ended by telling it is less than or equal to 5 mm invasion. So 1B means definitely it is more than 5 mm invasion. Okay. So invasive cancer with measured deepest invasion is more than 5 mm and the lesion is limited to the cervix uteri and with the size measured by maximum tumor diameter. Again, it's divided into B1, B2, B3. B1 is more than 5 mm but less than or equal to 2 centimeter. Remember, 2 centimeter is also included in B1. So more than 5 mm, less than or equal to 2 centimeter. B2 is more than 2 centimeter but less than or equal to 4 centimeter. So 4 centimeter means it is B2. 2 centimeter means it is B1. If it's more than 4 centimeter, then it becomes 1B3. Okay, so stage 1 is done. Now let's go to stage 2 where the CA invades beyond the uterus but has not extended to the lower third of the vagina or to the pelvic wall. So this is again divided into 2A, 2B. 2A means, so imagine a uterus, cervix, first where it will go? Down, upper two-third of the vagina, right? So 2A becomes involvement is limited to the upper two-third of the vagina without any parametrial involvement. Without any parametrial involvement. Again, it is divided into 2A and 2A1 and A2, where the invasive cancer is less than or equal to 4 centimeter in greatest dimension. That is 2A1. A2 is more than 4 centimeter in greatest dimension. Okay. So basically 2 means upper two-third of the vagina. Again, it is divided into 2A1 and A2 depending on the size. Now, what is 2B? You all know it is parametrial involvement. 2B is always parametrial involvement, but it doesn't go to the pelvic wall. So stage 1 is done, 2 is done. Now let's go to stage 3. So stage 3 means definitely upper two-third we already discussed, vagina. Now what is left? Lower third of the vagina, or it goes to the pelvic wall, or causes hydronephrosis or non-functioning kidney, or it involves pelvic para-aortic lymph nodes, right? So again this can be divided into 2. Remember, C is always lymph nodes. What can A and B be? So A, it should be lower one-third of the vagina. Okay, it is lower one-third of the vagina. No extension to the pelvic side wall. So what is 3B? Definitely the other way around. That is extension to the pelvic side wall, hydronephrosis or non-functioning kidney. C is, as I told you, it's always lymph nodes. And lymph nodes can be 3. C1, C2. C1 is pelvic and C2 is para-aortic. Okay. So if it's represented as R, that means radiologically you are detecting lymph nodes. If it's P, that means pathological positivity of the lymph node is confirmed. Now, last stage is 4. That is the last stage. As you all know, CA extends beyond the true pelvis or has involved the mucosa of the bladder, rectum. A bullous edema as such does not permit a case to be allowed in stage 4. So if a bullous edema is mentioned, remember that it's not stage 4. 4A is adjacent pelvic organs affected and 4B is always distant spread. So this is all regarding the staging of the cervix. So now let's discuss some questions based on this. So first question, 48-year-old woman has a 3.5 centimeter cervical tumor confined to the cervix. No nodal involvement. So you all know 2 more than or equal to 2, less than or equal to 4 centimeter. It is B, that is 1B2. Okay. So 1B1 is again less than or equal to 2 centimeter. If it's more than 2 and less than or equal to 4 centimeter, it's B2 and more than 4 centimeter, it is B3. So here the patient is 1B2 because she's having a 3.5 centimeter tumor. MRI shows 2.5 centimeter cervical tumor with para-aortic lymph node. So we all discussed that it should be C, right? 3C. So if it's pelvic, it's C1. Para-aortic means it is C2. So if it's confirmed, MRI is showing, that means it is confirmed by biopsy. MRI is showing, but it is confirmed by biopsy. So that means we have to indicate P for that. So the answer is D, which is 3C2P. So that's all regarding the staging and questions based on that. Now we'll discuss stage-wise management. So if at all you're learning the staging, learn the management also side by side, and it is quite easy to learn like that. So figure staging, take 1A1 and 1A2. Okay. So 1A1 with no lymphovascular spread. no lymphovascular space invasion. If it's stage 1B1, the preferred surgery is conization. Especially if you are getting clear margins, you can limit your treatment with conization. Fertility option, if the patient wants fertility also, conization can be done in stage 1A1, but there should not be any lymphovascular space invasion. And there is no need to assess the pelvic lymph nodes in this case because there is no lymphovascular space invasion. The alternative availability is definitely intracavitary chemoradiotherapy. Now, stage 1A1 with the lymphovascular space invasion, what are you going to do? Okay, so here, what we can do is we can do an extrafacial hysterectomy if the patient has completed family, or else we can do conization, but along with that, we have to do a lymphadenectomy. Another option is a simple trachelectomy you can do, but yes, you have to do a pelvic lymphadenectomy along with this. So that's all regarding 1A1 and 1A1 with and without lymphovascular space invasion. So let's discuss about stage 1A2. In 1A2, what we have to do? We have to anyway go for a pelvic node assessment, and the treatment should be, if the patient has completed her family, we have to go for a type B radical hysterectomy with pelvic node clearance, or if the patient wants fertility, 1A2, we can always offer her a radical trachelectomy with pelvic node clearance. So this block is clear. Now let's discuss about the early invasive disease. So stage 1B1, 1B2. And remember, 2A1 is also considered as an early invasive disease, but it is less than 4 centimeter. So 1B1, if it is less than 2 centimeter and low risk, okay, so it is less than or equal to 2 centimeter, low risk. Standard option for the surgery is modified radical or simple hysterectomy. But definitely you have to do a pelvic lymphadenectomy. And there is a trial which is called as a SHAPE trial, which says that simple hysterectomy can also be considered here. It is not inferior to modified radical hysterectomy. So either you can do modified radical hysterectomy plus or simple hysterectomy, but definitely pelvic clearance should be done. Other option is always CCRT, but if surgery is possible, this should be the better choice. Now, another stage, the next stage that is stage 1B2, more than 2 centimeter but less than or equal to 4 centimeter. You have to do a type C radical hysterectomy plus pelvic lymphadenectomy. And here, what should we do? If the patient asks for a minimal invasive surgery, we have to tell the patient open is generally preferred over minimal invasive surgery. So generally open is preferred here. Now, 2A1. This is 2A1 but it is less than, for tumor size is less than 4 centimeter. Here, type C radical hysterectomy plus lymphadenectomy can be done. Only open approach is recommended. Another option for this is CCRT. But generally, we used to tell if you exclude this 2A1 less than 4 centimeter, otherwise we generally say that till 1B2 it is surgery. From B3 onwards it is chemoradiation. So 1B3, that is more than 4 centimeter, definitely it is chemoradiation. And other stage, that is 2A2, which is more than 4 centimeters, again it is chemoradiation. 2A is also chemoradiation. So rest all are chemoradiation only. And last stage, definitely you go for a palliative therapy. Immunotherapy is also discussed here. So let's discuss some questions based on this. A 32-year-old woman with stage 1A1 cancer, CA cervix, without LVSI, desires future fertility. What is the best option? Yes, definitely it is conization. If the margins comes as clear, then definitely you need not go further. Only conization is enough. 29-year-old patient with stage 1A2, no LVSI, wants fertility preservation. What is the best option? So here the option is going to be radical trachelectomy, but you have to do lymph node clearance. Because it is stage 1A2, you have to do a lymph node clearance. Pelvic lymph node assessment you have to do. 42-year-old patient with stage 1B1, that is 2.5 centimeter, asks for So it is not 2.5, it should be less than or equal to 2 centimeter. Ask for laparoscopic radical hysterectomy. Based on LACC trial, what is the most appropriate counseling? So based on this trial, what we have to explain to the patient? We have to explain to the patient that it is associated with higher recurrence. So it's always better to go for an open surgery. 34-year-old patient with 1A2 disease is undergoing surgery. Which statement regarding sentinel lymph node mapping is correct? So basically, we have to understand the answer is sentinel lymph node mapping reduces lymphatic complications. Okay, so there was a trial called as the Cervical 2 trial, which shows that if you do sentinel lymphadenectomy, it actually lowers the lymphatic mobility or morbidity, and the similar recurrence free interval survival is also noted in this group. So when will you go for sentinel lymph node mapping? It is recommended for stage 1A to 1B2. So this is what we discussed about the Cervical 2 trial. A 45-year-old woman has a 5.5 centimeter cervical tumor confined to the cervix, no distant metastasis. So what is it? It is stage 1B3. So it is going to be chemoradiation. So a word about PD-L1 testing. So program death ligand 1, that is a full form of this. What is it? It is actually a protein expressed on the tumor cells and the immune cells like lymphocytes and macrophages. This actually binds to PD-1 receptors on the T cells. So when this PD-L1 binds to the PD-1 receptor on the T cells, it suppresses the T cell activity and the tumor actually escapes immune attack. So that means, in another way, cancer actually uses this PD-L1 to switch off the immune system. So why are we testing this? Because there are some drugs like nivolumab, pembrolizumab. It actually blocks this pathway, PD-1 and PD-L1 pathway. So what happens? These are actually called as immune checkpoint inhibitors. So there is this actually it is called as immune checkpoint inhibitors. But these will be effective provided if PD-L1 is expressed, right? So that's why we are testing for PD-L1. So before giving immunotherapy, we have to test for PD-L1. If it is positive, then that means we can try immunotherapy. So based on that, there is a score called as CPS score. If it is more than or equal to 1, the patient is eligible for pembrolizumab, and if it's more than or equal to 10, higher responses is the likelihood. So it is more common in squamous cell tumors, squamous cell carcinoma, neuroendocrine tumors, and it is rare in gastric type of adenocarcinoma. So a patient with a recurrent metastatic cancer has PD-L1 CPS score of 12. What is the most important appropriate systemic option? We all discussed now. It is pembrolizumab. So that's all. Thank you for your patient listening. All the best for your exams. Do well.